So, you have finally taken the step and you've called a therapist and you're about to start therapy. What the heck exactly is therapy? Well, today we're going to talk a little bit about what is therapy, what are the roles of a clinician, what are the roles of your provider, but also a little bit of insider knowledge about what the heck is a theoretical orientation, why would therapy work in general, and how to start asking some of those questions of this new clinician that you might be seeing, or even asking this of your current clinician. So, when we talk about theoretical orientation, this is actually putting a big old spotlight on us as the clinicians. Theoretical orientation is basically a belief structure of the clinician. It is their approach to clinical service. What is our opinion about why therapy works, or what we call like theory of change model? So there are, I think we're up to like 212 theoretical orientations. We got a whole bunch of them, and that can feel super confusing. You'll see words like cognitive behavioral therapy, psychoanalytic, psychodynamic, person-centered, eclectic, integrated, positive psychology. There is so many, and it can be really confusing, especially for you if you are the patient seeking out a clinician and you're dealing with those concerns if that's bringing you to therapy in the first place and going, well, how the heck am I supposed to suss out a clinician? I am a huge advocate. When you are starting to work with clinicians, you get to do some therapist shopping. Now, there are some limitations to this, especially when we look at, are you trying to find someone who has similar demographics to you, who is within your insurance carrier? That's a whole nother ballgame within that. Who's in your cost? Are you looking for someone in person? Or are you looking for virtual service? There is a giant list of things that you're probably doing and running those checklists in your head when you're looking for a clinician. So unfortunately, I am going to add this one to that checklist as well, but I promise I'm doing it for good enough reasons. Because the theoretical orientation of the clinician is basically the framework in which they are going to approach you in the therapy room. What different prompts are they going to ask? What different queries are they going to make? What different interventions? How are they going to approach not just you as a person, but how they are going to interact with your treatment goals? How are they going to provide you with service? The theory of change model talks a lot about, as clinicians, what is our belief structure, or what is our foundation on why would therapy work? What the heck is going to change, or what is going to be needed to change in order for long-term success, recovery, even remission to occur? So when we're thinking of theory of change, I'm going to speak a little bit more about myself in this context because I can only speak about myself. When it comes to theoretical orientation, it's very personal. It's a little bit like a personal blood type, but this one you get to choose. So when you think about theoretical orientation, for myself, I identify as a cognitive behavioral therapist, or CBT. Fun fact, when I was getting my sex therapy certification, I was going through a sexual attitudes reassessment event, and they said, okay, we're going to talk about CBT now. And I was so excited because I'm a giant CBT nerd. And then they're like, yeah, we're going to talk about cock and ball torture. And I went, I need to specify which type of CBT I do. So to emphasize, I do cognitive behavioral therapy, or CBT, as a clinician. Now, what CBT to me means, my theory of change, is that for a patient who is experiencing distress, I am looking at the way that their thoughts, feelings, and behavior all interact with each other, and the ways in which those interactions can result in mental health conditions. They can result in unhelpful cognitive patterns, avoidant behavioral patterns, physiological anxiety sensations. So anytime I approach a new patient, or even all of my patients that I see, I'm constantly thinking about the ways in which their thoughts, feelings, and behaviors are interacting in their world that's leading to unhelpful or undesired outcomes. So for me as a CBTer, the way that I approach it is I look at various cognitive belief structures, ways in which a person is thinking about themselves, other people, and the world around them. And I'm keeping an ear out for what I call unhelpful cognitive patterns. Now, unhelpful in this context is very vague. It's kind of supposed to be. Your thoughts are not right, nor are they wrong, despite what sometimes OCD likes to tell us. But we're not looking at rightness or wrongness. We're looking at, is this a helpful thought to you, or is this an unhelpful thought, or even a harmful thought to you? If I hold the belief that I am a piece of shit, that's probably not going to lead me to feel super good about myself, and probably going to lead to patterns of social isolation. I might engage in self-harm. I might engage in I might notice myself not sleeping because I'm constantly thinking during the night about what a terrible piece of crap I am. That pattern, again, look at how they're interacting with each other, probably not having the biggest helpful impact on a person. But this is where we get to individualize a patient's care utilizing the theoretical orientation, where I want to listen for the particular patient's thoughts, feelings, and behaviors, and taking into the multiple complexities of that person, the unique variables. This is where you look at culturally competent CBT, so where you get to include a patient's diversity factors, being able to look at the time in which they were raised, the environment they were raised in, even their hobbies, their interests, language, looking at their cultural experience. You get to take all of those multiple facets of this person and think about the way that all those three main variables are interacting with the way that that person defines and experiences themselves, other people, and the world around them. Overwhelmed yet? It's okay. The reason that we're going through it is when you are looking at a clinician, particularly someone who might be a CBTer like myself, I'm pretty active in the room. I'm going to be asking a lot of questions. I'm going to be engaging in a lot of Socratic questioning. You sure as heck are going to be getting homework from me. The homework is going to be always bound by that theory of change. Every intervention, every single homework assignment I give to a patient is designed to identify, challenge, and modify thoughts, feelings, and behaviors in a way that we can reduce the level of distress a patient is experiencing. Again, we get to incorporate the patient's individual factors to that theory of change and match those two experiences. That's how you get a personalized care model. This is what I love about CBT, is it's just that framework, thoughts, feelings, behaviors, but then you get to match that theory onto the patient themselves. This is where you get to think about what homework assignments, what different behavioral modification, what different specific interventions are going to match to that patient, and what their current distress levels are, what their current diagnoses might be, what their goals are, honestly, for therapy. Because if your goals are to just have someone listen to you, that is an awesome goal. You're looking maybe more for supportive psychotherapy. That's involved and that's included in a lot of other theoretical orientations. But if you just want someone to listen to you, you might be looking for more of a supportive model. If you want someone who's going to be more direct with you, who's going to give you very tangible homework assignments to do, who isn't just going to give you that support, you might gear a little more towards the CBT model. But this is why asking your clinician, hey, what is your theoretical orientation? And honestly, if they go, well, how dare you ask me what my theoretical orientation is, you fire them immediately. Our theoretical orientation as clinician is what guides not only our approach to you, but our entire approach to the field. So if a clinician gets offended by asking a very foundational question, you're going to probably not feel safe enough to even open up the most surface layer of your onion. So when you're seeking out a clinician and you're asking the question of, well, I'm at least ready to go see someone, then you might be asking, well, what the heck do I want out of them? When we look at the clinical or the therapeutic relationship, it genuinely is a relationship. We are working together to meet your treatment goals. And if you have a moment of pause and go, crap, what are my treatment goals? Good thing you're going to be working with a clinician, hopefully, who will work with you on that. Because I do tend to take a CBT-based approach to working with my patients, I look at in what ways would they like their lives to be different. What current patterns of thoughts, feelings, behaviors, again, you're noticing a sound of repetition here, what of those thoughts, feelings, and behaviors in a patient's life do they want to be different? In what way are they causing harm, distress, or just making it more difficult for a patient to experience their life? This is where you do collaborative treatment planning with your clinician. That's kind of part of our goal, is to work with you. So if you're looking on any online listings, Psychology Day, you're looking at websites and bios of clinicians, and you're getting a lot of data about them, take a moment and pause for yourself of, what are my goals for therapy? What am I hoping to achieve? What do I want to be different in my life? What is the type of approach that I would like? Do I want someone who is going to just give me support and that is it? Or do I want to go learn things? Do I want to learn things about myself? Asking those different questions. Not to mention, am I ready to open up to those individuals? That's where our listings online as clinicians are really helpful of what type of clinician are you looking for? Not just their theoretical orientation, their background, their political affiliation, what their passions are. Are you looking for someone who comes from a similar ethnic background as you? Are you looking for a similar religious environment? Are you looking for someone who's closer to your age? Being able to take those moments of pause when you're looking at clinicians and going, well, what about that would be important to me? Because therapy is a relationship. You are going to be interacting with this person. You're hopefully going to be sharing with them really difficult experiences or just things that you really genuinely don't get to talk about that often with other people in your life. Feeling safe, feeling comfortable, feeling heard, being a non-judgmental space, that is the core fundamental of all therapeutic services. Then theory of change is how do we then make those changes in your life. But if we don't even have that core foundation of safety, you're not even going to get to the next part. So again, fire them if that's not working. Which then prompts, what do you need to feel safe with the clinician? Not just physically safe. What do you need to feel emotionally safe, cognitively safe? What do you need in order to open up so that we can do those next theory of change approaches in your clinical work? So some examples that you might want to ask either yourself or even a clinician is, what is their theoretical orientation, or even what is their approach to care? I've had some people ask, like, how long have you been doing this for? What settings have you worked in before? Probably the most common one I get from my patients is, have you ever worked with this before? That's usually patients asking, have you ever dealt with someone like me? Which harkens back a little bit to my Am I Normal post, because that is so common. You're looking at the scope of practice of your clinician. So for me, as someone who my specializations are in anxiety disorders, trauma-related disorders, and sexual health and functioning disorders. Those are my three babies. I love them so very much. It's within my scope of practice or my scope of competence. If you are someone who maybe is experiencing a psychotic episode for the first time, or who's getting sober for the first time, whilst I have some experience with that in my clinical background and in my clinical training, I may not be the best fit for you because that's not my specialization. So when you are asking clinicians, you are asking them their specialization, you are asking them, have you ever worked with someone like me before? And if they scoff and go, well, I don't talk about other patients or blah, blah, blah. Again, that's not super honest and helpful to you, but go, hey, yes, I've worked with this before, or go, you know what, this is actually not something I specialize in. Let me get you a list of referrals that may be a better clinical fit. Now that feels a little like rejection, doesn't it? Ooh, so you might notice a little bit of a stinging. But here is the thing. If a clinician is not a good fit for you and they're treating your condition or they're treating what you are bringing to the therapy room just kind of willy-nilly and going, I guess I'll try, and that is not a great thing for a clinician, because it often means that they might be practicing out of their scope of competence, out of their scope of practice. They might be engaging in unethical practice. That is not super great. So even though that might sting a bit like a rejection, I want to make sure that you are with the clinician who is going to be the best friggin' fit for you and not just whoever is on the table. The best fit may not be the most perfect fit for you. So I know that's a lot of information to throw at you all at once, so thank you for sitting with me today and going over it. If you have other questions, please put them in the comments down below. And if you'd like any more videos or any other topics you want me to discuss, or even review the topics of mental health that I have already gone over, check out some of these links right here. And before you head out, feel free to like, comment, and subscribe. I'll see you next time.